Good afternoon, everybody. Welcome to our September webinar for the Optimizing Newborn Nutrition Initiative. This webinar is titled Golden Opportunities for the Golden Hour. We have a couple of updates before we get started with our main topics for today. A little reminder about the MPINC survey. The CDC survey closes on October 17th, so there still is time to have your hospital respond and submit their survey. Only 27% of Georgia hospitals have responded, and so we really want to see that number increase. And again, a little over a month left to get those surveys submitted. Hospitals have to complete and submit their survey to receive that individualized hospital report and to be included in the state, regional, and national level data. And if you need more information about the MPINC survey, there's some great FAQs on the website that's listed there. We can also stick this in the chat, or you can email mpinc@cdc.gov. So please look into whether or not your facility has submitted the MPINC, and if not, encourage that submission. There is a Speak Up training. We mentioned this last month. We just wanted to put it on the radar again. It's offered through the Institute for Perinatal Quality Improvement. Those sessions are going to be offered in October and May. And just for a little more information on that Speak Up training, it's through the Institute for Perinatal Quality Improvement, and it's their Speak Up Champion Implicit and Explicit Racial Bias Education Training. It's a total of 8 hours, and that's split over 2 days. So the October dates, which we're hoping to fill first, are October 12th and 19th, and then there will be another training opportunity in May. It's online. It's a live, virtual, interactive training, and it outlines quality improvement strategies to support individuals and groups with dismantling racism, providing quality, equitable care, and reducing health disparities. You'll see their target audience are health professionals who support and care for patients before, during, and after pregnancy, or professionals that care for newborns. This is for Georgia participants only. Both the October and May sessions are only Georgia participants. So great opportunity here. It is free. You'll see your learning outcomes there. You do come away from this training with a quality improvement action plan for ensuring equity in perinatal outcomes. It's a really wonderful training. If you've not taken it, we encourage you to, especially because these are Georgia specific trainings and free for you all to participate. I did send information in our last webinar recap. I'll send it again after this webinar so that you have that flyer and information on how to register. And if you have taken Speak Up before, you can pass this along to other members of your team at your hospital so that they can participate and have that training. And I'm going to hand it over to Dr. Patel.
Thanks, Kimberly, and good afternoon, everyone. I'm going to share some of the updates on where we stand with some of the QI, and also to get a few minutes of your input on, we talked a little bit last month about smart aims. One of the exciting things now is we actually have a baseline of how we're doing in Georgia within the collaborative in terms of nutrition and yep, setting some goals of where we hope to go. I always like to start with each of our webinars on our key driver diagram. This is our roadmap for this initiative. We started in July with collecting data. Last month, we talked about time as tissue. Really excited for today's webinar, which is going to be on golden opportunities for the golden hour, and also to learn from what people within Georgia are doing. And so thank you to the team at Northside Gwinnett, who Claire Eden's going to introduce, for presenting today and sharing some of the opportunities we have to address some of these interventions that tie in to drivers with the eventual goal of moving the needle on the smart aim for both Georgia and also for your hospitals. Now, here's the results for the data from the audits. As a reminder, we use a sampling approach, which means we just ask you to take 10 babies within each month and focused on 3 performance measures. And so this is a sample. This is really to give us a snapshot of how you're doing and also how we're doing as a state. You have the opportunity. I know some of the hospitals are building in additional measures on some of the audits that allows you to learn from, for example, if an infant receives formula supplementation the last week, why was that? And I think that might be a good opportunity, something that you don't have to submit to the GaPQC, but something that might be useful for you to track to understand what's the reason for some of your performance that can help you target improvements. So thank you for all of the hospitals who've been submitting. We've really been pleased with engagement. So we started off last month with 77% of the hospitals submitting for their units, and we've had 73% for the audit we had last month in August, and even higher if you look at the number of hospitals, because several of the hospitals are participating both in the mother baby and the neonatal initiative. And as a reminder, we have about a mix of 50-50. So about half of the hospitals are working on improvement in the well newborn population and mother baby unit, and about half are working in the neonatal intensive care unit, and that spans both birthing hospitals as well as some of our non-birthing hospitals. So this is the primary measure for our collaborative, and this is human milk as a first feeding, and you can see relative stability in terms of where we are in establishing a baseline for how we're doing in Georgia. And so I think both of these points give us a good idea of where we stand in terms of how many of the infants within our GaPQC hospitals are receiving human milk as their first feeding. And as I'll share at the end, this is going to be useful for us to know where our baseline is and then to target where we hope to go. We did have some discussions and questions from centers about what should we do if the babies are born in and out of the hospital and then come to you. And so for that, we wanted just to clarify that this is the first feeding at your hospital. So we want you to collect data on what was the first, the type of feeding for the first feeding that occurred at your hospital, not for babies that might have received some nutrition before for those hospitals that are participating that accept outborn babies. This is our data on formula supplementation the last week. So if you look here, it's still about 50 to 60% of infants in our GaPQC hospitals are receiving some formula, whether that's in the supplementation in addition to human milk. And if you look at the prior slide, it probably means that a number of babies who are getting human milk as a first feeding are getting some formula supplementation. And I think this, both for the well newborn setting and the NICU setting, is an opportunity to look at. And I'll highlight this, and I know Claire's going to mention this as well, but the breastfeeding report card was just released. And if you look at some of the measures, and I think if you looked at where does Georgia stand, and this is a report card that's done from the CDC, it uses some of the MPINC data that we've mentioned before, and it gives us a sense of how Georgia is doing compared to the rest of the US and measures. And one of the areas that we had as an outlier is the number of breastfed infants receiving formula before 2 days of age. And so Georgia was 48th, worst in the United States, in terms of the percent of newborns that receive supplementation. This report card's only released infrequently, and so one of the benefits we have now is a snapshot that tells us how we're doing in almost real time and allows us to target improvement. But I think this would say that this is a good opportunity for us as a state to try to address. And tied to that, from our first audit of structure measures, I think this is also a good opportunity. We hope to have, we're going to do this again in January of 2023, and we want to see us try to move the needle on this. And so one of the areas where we had the lowest response was hospitals that had a policy on supplementation. And I think this ties into where we stand in terms of our performance of the percent of infants that received formula, how we did in the CDC report card, and policies. And so as you listen to these webinars, as you hear about opportunities for improvement, think about how you might incorporate this into your own hospitals, ideally through testing on small scale. You heard about that last month. And also about how those tests and how those changes you make might be incorporated into policies that ensure sustainment. And please reach out to us. We hope to allow this to be a forum for hospitals to share policies with one another, so that you don't have to create something new on your own. You can learn and adapt from other hospitals part of this collaborative. And then this is our third measure, which is the timeliness of breast milk and breastfeeding within 6 hours of birth. We know this is a challenge for some of the hospitals, so there's a couple that have had difficulty with this, but the majority, I'd say over 80%, are able to collect this data, and you can see where we stand there. About 50% of the infants audited are meeting this measure. So how do we use this to guide improvement? I think one of the things that you have all helped us do is to give us a snapshot of how are we doing with newborn nutrition, so we can optimize this in Georgia. You know, before this collaborative, if we wanted to know how are we doing in July or August of 2022 with nutrition, we almost have no real good data to give us a snapshot of that at a state level. And so we have some ideas now of how we're doing, and one of the things is where do we hope to go as a collaborative. And to do this, I think the focus is really to get tangible aims. And these aims should be specific, measurable, achievable, relevant, and time-bound. So we have set forward, and as you saw in the key driver diagram, we set forward, you know, SMART aims for the GaPQC, but these don't necessarily have to be, they could be, but they don't necessarily have to be the SMART aims that you decide to work on in your hospital. Our SMART aim is focused on our first measure, which is human milk as a first feeding. But you as a center may also decide, and we're going to be tracking data on formula supplementation the last week, that might be really a goal that you target in your hospital based on your own data. And we hope that the data we show from the GaPQC gives you an idea of being able to look at your own data to see how your audits are comparing with what the performance is for a state. And so I've updated this now that we have a couple of data points and we have some sense of the stability of our measure of kind of where we started. And so when we started and launched this initiative, we said we had a lot of blanks here in terms of where we hope to go. And we filled in some of those blanks. And so one of the things we'd like is feedback from you on kind of our overall SMART aim, which here we have is really to increase the percent of newborns in GaPQC hospitals. And we're ascertaining this from these monthly audits with human milk, either mother's own milk or daughter human milk as the first feeding. And we want to try to increase this from our baseline of 73% by 10% to a target of 80% by the end of this initiative. We've learned from other state initiatives that you know, moving these nutritional measures are challenging, and we want to try to have achievable and realistic goals, but we also want to try to target improvement. And so 10 to 20% is often one of the rough rules to try to see what you would achieve. But this is an opportunity before we move on to our speakers for today to get feedback from you. And so I'd ask you in your chat box, what do you think about this 80% target for us as the GaPQC? Give us your feedback on, is this about right? Is this too high, too low, and or suggest alternatives? And we'll take this back to our neonatal committee and set this so that for our next webinar next month, we'll have kind of a set target of what we hope to achieve. So tell us if you have thoughts on the SMART aim. And I would also say, using the same framework of thinking about in your hospitals, what do you hope to achieve by September 1st of 2024? And thinking about that could be working on human milk as a first feeding. It could be decreasing the percent of newborns with formula supplementation last week. It could be increasing the percent of timeliness of breastfeeding with 6 hours. I think those are all options that you might work on locally based on where you think the biggest opportunities are. And so we'd love to hear your feedback. You can put some of the feedback in the chat box, or if you have something that you'd like to mull over and think about after this webinar, please email Kimberly, and we can bring it back to our neonatal committee to consider this as we set this. SMART aims are flexible. So one of the things that is always important to know is that key driver diagrams and SMART aims are your goals, but as time goes along, we do have opportunities to consider updates to the key driver diagram and to the SMART aim, but we really do want the input of all of you on this. So I'm going to stop sharing my slides there, and I'm going to go ahead as we give a few minutes for chat box. I see one comment here that the 80% is a good starting point, and so please give some comments in the chat. And so I'm going to go ahead and turn it over to Claire Eden, who's going to introduce our speakers for today and with the Georgia AAP.
Hi, everyone. I want to give a very big and special thanks to the team from Northside Gwinnett. They've been really good sports and willing to prepare and share about both their wins and their areas of opportunity, kind of especially in the current healthcare climate with regard to golden opportunities in the golden hour. So I'd like to particularly welcome Jeanette Hairston, who's the clinical nurse manager for maternal, infant, and lactation, and also Jessica Korn, who's the neonatal clinical nurse specialist. If I'm remembering correctly, I think Jessica is going to start. Is that right?
Thanks, Claire. Yeah, that's right. Can you hear us okay?
Yeah, welcome. Go ahead.
Awesome. Yeah, thank you so much for giving us the opportunity to share today. We're also joined by Becky Moore. She's one of our lead lactation consultants, so she's here for moral support. And of course, our hospital team also includes clinicians from labor and delivery, NICU, maternal infant. We have providers both from the OB area and pediatric, and nursing staff, and staff also from prenatal clinics that work on our collaborative team. We have been enrolled with GaPQC initiatives previously, where we participated in the infants at risk for neonatal abstinence syndrome. And then for perinatal initiatives, we've participated in postpartum hemorrhage and hypertension. We're currently enrolled in the neonatal optimizing neonatal newborn nutrition as a learning collaborative. So we are really excited to share. Next slide. All right. So what is skin-to-skin contact after birth and the golden hour? The golden hour encompasses a set of evidence-based practices that contribute to the physiologic stabilization of the mother-baby dyad after birth. Important elements of the golden hour include delayed cord clamping, skin-to-skin contact for at least an hour, and the performance of newborn assessments on the maternal abdomen, and also delaying non-urgent tasks such as bathing for up to 60 minutes, or through and also early initiation of breastfeeding. The golden hour has multiple benefits for both mom and baby. AAP defines skin-to-skin care as the practice of placing infants in direct contact with their mothers or caregivers, with the ventral skin of the infant touching the ventral skin of the mother. Baby could be naked or dressed with just a diaper, but we want to maximize the surface-to-surface contact between the mother and caregiver. And then we can put pre-warmed blankets over baby to help to facilitate thermoregulation and leaving baby's head exposed. The Academy of Breastfeeding Medicine outlines similar practice in their clinical protocol for peripartum breastfeeding management for the healthy mother and infant at term immediate postpartum. They emphasize that this helps to facilitate latch and feeding, ideally within an hour of birth when it's initiated in delivery, the operating or recovery room. Baby Friendly USA also offers similar guidance, clarifying that the infant will remain on the abdomen until the cord is clamped and cut, and then the infant moves his or herself up to the chest, or the baby is placed up on mom's chest above the sternum. Next slide. So safe positioning during skin-to-skin contact is important for reducing the risk of sudden unexpected neonatal or postnatal collapse. We want baby in a position where we can see the baby's face, head in a sniffing position, nose and mouth not covered, to chest with mother and the legs in a nice flexed position. AAP recommends continuous monitoring for the first few hours with lapses in observation not exceeding 15 minutes. Next slide. So skin-to-skin care is recommended for all mothers and newborns, regardless of feeding or delivery method, immediately after birth, as soon as the mom is medically stable, awake, and able to respond to the newborn. We want to continue this for at least 1 hour, and this is defined in the World Health Organization's 10 steps to successful breastfeeding. It's also in the Academy of Breastfeeding Medicine protocol number 5 during the immediate postpartum period. The infant may be dried and assigned APGARs in skin-to-skin position, and the initial physical assessment can be performed while the infant is placed on the mother, delaying non-urgent procedures such as weighing, measuring, administering eye prophylaxis, as well as vitamin K up to 6 hours after birth. And the initial bath, delaying the initial bath, can enhance early parent and infant interaction and breastfeeding success. Next slide. So why do we want to promote this skin-to-skin contact? There are benefits for both mom and baby. Research is extensive. It's been researched extensively as a method to provide improved physiologic and stability for both newborns and their mothers. These benefits are optimized when immediate skin-to-skin contact and early initiation of breastfeeding take place in tandem. Skin-to-skin contact decreases crying and provides cardiorespiratory stability, especially in late preterm newborns. It's also been shown in numerous studies as a method to decrease pain in newborns being held by their moms and dads. Facilitates newborns' natural rooting reflex that helps to imprint the behavior of looking for the breast and suckling. This can help to populate the newborn's microbiome. It has been shown to stabilize blood glucose concentrations, and skin-to-skin contact immediately after birth stabilizes the newborn's body temperature and can help prevent hypothermia and reduce the risk of infant mortality. Increasing rates of breastfeeding ultimately have short and long-term health benefits such as reduced infection, reduced risk of obesity, cancer, and sudden infant death syndrome. Next slide. So skin-to-skin contact after birth is also very beneficial for the mother. Immediately after birth, it's been shown to decrease maternal stress and improves paternal perception of stress in the relationship. Experimental models indicate that mother-infant separation can cause stress, and the consequences of the stress are impactful for the hypothalamic and pituitary adrenal axis. A trial examined the relationship between skin-to-skin contact and maternal depression and stress. Depression scores and cortisol concentrations were lower over the first month among postpartum mothers that were provided skin-to-skin contact compared to those who were not. A recent study suggests that skin-to-skin contact and breastfeeding within 30 minutes can reduce postpartum hemorrhage. For mother-infant dyads, it enhances the opportunity for an early first breastfeeding, which can lead to readiness to breastfeed, organized breastfeeding suckling pattern, and success in exclusive and overall breastfeeding, even after cesarean deliveries. There's evidence that shows a benefit for mothers after cesarean who practice skin-to-skin care as soon as the mother is alert and responsive, and increased breastfeeding initiation, decreased time to the first breastfeeding, reduced formula supplementation, and increased bonding and maternal satisfaction. Implementation of skin-to-skin care and rooming in have also been shown to impact overall breastfeeding rates and decrease racial disparities in the U.S. Breastfeeding initiation increased from 66% to 75% for all races combined, and exclusivity increased from 34% to 39%. Initiation and exclusive breastfeeding among Black infants increased from 46% to 63%, and from 19% to 31%, respectively. Next slide. Okay, so who is this important for? Skin-to-skin care is recommended for all mothers and newborns, regardless of feeding or delivery method, immediately after birth, as soon as mom is medically stable, awake, and able to respond, especially for those that are at risk for decreased breastfeeding success. In preterm infants, skin-to-skin care has been shown to result in improved autonomic and neurobehavioral maturation and gastrointestinal adaptation, more restful sleep patterns, less crying, and better growth. Get to the next slide. Dyads who experience skin-to-skin contact after surgical birth demonstrate an increased success in overall breastfeeding, with a reduction in time to first feed, decreased formula supplementation, and improved bonding. Prioritizing skin-to-skin care after surgical birth can have a significant impact on improving exclusive breastfeeding during the first 48 hours for infants born in Georgia. So how do we approach implementing skin-to-skin care during the golden hour? It helps, of course, if you have a guide to follow. The Academy of Breastfeeding Medicine includes some key practices in their clinical protocol, number 7, for modeling maternity policy supportive of breastfeeding. To promote skin-to-skin contact immediately after birth and support breastfeeding as part of the delivery of essential quality care during labor and delivery. First, involving an infant feeding and breastfeeding committee whose primary focus is breastfeeding. The team members can help to monitor and oversee the implementation at the level of other hospital quality improvement committees and clinical practices. We want those team members to be multidisciplinary and culturally appropriate, composed of representatives, decision makers in a variety of different areas, meeting routinely at least every 6 months for monitoring purposes, and to establish a mechanism or a method for data collection directed towards routinely tracking breastfeeding and mother-infant care indicators and policy implementation. Early initiation of breastfeeding and exclusive breastfeeding are considered sentinel indicators. So for us, our Feeding the Healthy Newborn policy incorporates the 10 steps to successful breastfeeding outlined by the World Health Organization as routine procedure. The first step in our procedure is establishing and maintaining a written breastfeeding policy. And it also includes a step for helping moms to initiate breastfeeding within 1 hour of birth by implementing skin-to-skin contact for all couplets, regardless of feeding choice immediately after birth, for at least 1 hour or until the first breastfeeding is complete. Acknowledgement of our policy is required across the facility as part of our hospital onboarding. We can go to the next slide. Okay, so this is just a small picture of a few trends related to skin-to-skin care at delivery for our patient population at Northside Gwinnett. This data was pulled from a random sample of couplets earlier in the year. It's not fully exclusive of confounding factors, but demonstrates some general relationships for our patients. So the first pie chart breaks down the racial and ethnic background of patients with documented completion of skin-to-skin care at delivery. The majority is represented by Caucasian patients, so there may be an opportunity here for a focus on racial disparity to improve breastfeeding for those groups that are most at risk. The bar graph compares percentage rates of different factors between patients with documented skin-to-skin birth, and that is the blue bar, and those without, and that's the red bar. Skin-to-skin contact is documented more frequently after vaginal births compared with C-section deliveries. The records with documented skin-to-skin care at delivery also showed an increase in exclusive breastfeeding and initial breast milk feeding rates over those without documentation of skin-to-skin at delivery. There was also the average weight loss at the time of discharge was a little bit less with those with documented skin-to-skin at delivery. We can go to the next slide. All right, so what kind of challenges can be expected with implementing skin-to-skin care during the first hour for all patients? Surgical birth scenario, of course, needs some modification to facilitate skin-to-skin contact in the OR. Staffing for different birth scenarios and the mix of staff across departments, staffing crisis, utilization of temporary staff. Documentation is a challenge and can greatly impact data collection for process improvement. The culture of the department and routines, looking at approaching tasks differently to facilitate skin-to-skin care, such as changing the location of your assessments or timing of assessments. This can impact providers as well, as their routines for procedures and overall buy-in can be a factor. So now I'm going to pass it over to Jeanette. She's going to expand a little bit more on the challenges that we've encountered and the things that we're doing to work through them.
Hello, everybody. Thanks for joining us. So one of the first challenges that everybody can pretty much identify with, probably within their organization, is a surgical birth. So skin-to-skin contact in the OR for C-section births. What does that look like? Well, here it looks like a sterile environment where the mom is strapped to the table, and a lot of the focus is on the surgical procedure and patient. And so the second thing is that safety concerns. When the patient is in the OR, there presents multiple safety concerns such as falling, collapse, primarily with respiratory considerations with our babies, risk of infection, thermoregulation from low temperatures of the OR setting, and what staff members would be responsible for the baby. So a lot of facilities don't have a designated staff member in the OR for that newborn. So of course, a clear plan is needed to provide staffing for both patients to ensure quality of care for the mom and the baby. Next slide. Challenges with staffing. Of course, as everybody knows, since COVID, there's always been that ongoing issue with just staffing the units. And with that comes staffing safe patient to nurse ratios. So of course, that sometimes there's even limited staffing when you do have that. So it can present a challenge. Inexperienced RNs, travel nurses, or limited staff. Training and education. Multiple different disciplinaries are needed to customize education and the admit team, and keeping track of that education and compliance can be challenging at times. And of course, COVID-19 considerations. There's been a lot of adaptations and modifications with COVID. Of course, at times there's reduced staff when the staff are ill themselves with COVID. The utilization of PPE and protocols, and of course, changes to staff ratios to making sure that the workflow is beneficial for the patients. Next slide. Another challenge, documentation. Done, but it's not documented. We could see that that is a common occurrence, that that a lot of the procedures or even things that nurses do are not documented when they're in fact done. And then who documents? Do we document on the mom, or do we document on the baby's chart? Do we document at both? At birth here at our organization or facility, there is a mom and a labor and delivery nurse and a baby nurse. So at birth, the baby nurse assists the primary RN and then when the baby is considered stabilized, does the primary RN remember to complete the skin-to-skin documentation started by the baby RN. So this is a kind of issue where it can become with handoff communication when, they're focused on giving the mom care or answering questions and assisting with feeding, that maybe the thought about charting has been forgotten. Where do you chart? Historically, before we have changed over to our new electronic health system, Cerner, the baby nurse would document on a separate piece of paper, which was easily accessible. And so even after you were done and you were collecting your papers, you would say, oh, I'm missing that documentation. Let me go ahead and fill it out, and so forth. So EMR standardization within the system, at times it changes from one designated place to a different place, or at times there's multiple different areas that you can complete the documentation. And so sometimes people document in one place and not the other, and that can cause a complication. So, for example, one of the hospital's clinician had a school project focusing on skin to skin, and she was also tracking charting compliancy. She was able to determine that the skin to skin was being done and not documented. So she would do an open medical record review and coach in real time with the RN to complete the skin to skin documentation. She was able to see an increase in compliancy after a review after that short period of time. But when she went back to do a review a month later, she had seen a decrease in compliancy. She was able to determine that another group of travelers had cycled out of L&D, and perhaps the education and training had not been hardwired or completely retained by the new or travel staff because of turnover. Next slide. So another challenge is culture. Change is difficult. A lot of people are resistant to new practices. They may be uncomfortable, or they're very comfortable with uncomfortable with the change in routine and very comfortable with the routine that they currently have. And sometimes people can be so focused and task oriented that they just want to complete that task on the checklist. And, with that being said, that might be the procedures that can be delayed. Of course, we all understand that change is hard and it involves everyone. So of course, we have to help and enlist these naysayers, streamline as much as possible with documentation, that there can be a change to this culture that might be persistent. Next slide. So challenges to become opportunities. I'm just going to kind of give a background about what it looks like here at the organization or at the campus that we're at. In the first hour of maternal and baby recovery, the standard care practice is for the couplet to have uninterrupted skin to skin to promote all benefits outlined in the previous slides, as we already know. In a spontaneous vaginal delivery, immediately after birth, the baby is placed on the mother's tummy by the provider, and nurses will support them and monitor the stability of both patients to initiate and continue bonding and feeding. Typically at this time, the nurse will educate on proper positioning, head turned to the side, etc. for safety. Providers are adapting and overcoming and will actually complete vaginal repairs with baby skin to skin. So I can attest that I would say majority, if not all, vaginal deliveries that are stable, babies are going skin to skin. Skin to skin will be initiated regardless of manageable risk factors such as late preterm, LGA, SGA, hypoglycemia, and COVID. The few exceptions when skin to skin is not possible is when a baby is ill or suffering from acute respiratory distress syndrome, because immediate medical care precludes skin to skin times but will be deferred until mom and baby are stable. The priority is to reconnect couplets and resume skin to skin as soon as possible. But of course, there are exceptions with certain blood pathogens and unstable infant or mom or preterms less than 35 weeks that would interfere in immediate skin to skin care. In a cesarean delivery in the OR setting, it has been a challenge to have dedicated nurses to monitor the safety, or even if a potential need arises. So currently we have one provider that will coordinate with the OR team and NICU recess to ensure staffing to support skin to skin the entire time in the OR when the baby is placed on the mother. On another note, I personally have not heard patients' requests for skin to skin in those incidents. So there might be an issue with maybe provider feeling like it might be unsafe, or even the patient themselves. In most OR cases, as soon as the mother enters the recovery room, skin to skin is initiated as soon as when mom and baby are stable. We do delayed bathing in both instances of the vaginal and cesarean delivery. incorporate bands or straps in the OR to secure the patients together, and what that looks like to even increase the numbers or percentages for that skin to skin in the OR. Things that that we can attest to that we have in our practice that is directly related to staffing and education and training. We have established breastfeeding education and training with modules and 5 hours of hands-on training with the lactation staff to build knowledge and confidence when assisting mothers and babies from birth until discharge with skin to skin and breastfeeding. Currently, all permanent staff in labor and delivery, mother, baby, and admit team undergo this training and competency. We have made, of course, everybody has travelers, so we've made an abbreviated and highlighted module or CBL for them to complete that emphasizes the importance of the skin to skin and bonding and breastfeeding as well. And of course, with the new resident NICU residents, we have a group class that the lactation consultants complete with them so they can understand the importance and encouragement of that skin to skin and breastfeeding. We also work with education and training for the prenatal clinics. We have all, like I said, the providers complete the education modules, but we also send them with cards, script cards that they do weekly, starting as early as 16 weeks, but around 28 weeks, that's the topic where they talk about skin to skin specifically. And so that is kind of the expectation that we have given to them, and we're working on that. Breastfeeding class, we provide breastfeeding classes coordinated with the Georgia Department of Health. And they do education and on skin to skin and bonding at 2 different provider practices currently. Ideas to address for others, something that, you know, we can maybe give an idea for you is that, of course, with any new process, there will always be pushback, but give them the rationale about and prioritize bonding and feeding, and let them know that it is safe when it's done under the right, you know, not necessarily environment, because every environment is right as long as the baby is stable. That there can be a change to workflow. Assessments can be delayed, such as APGARs, procedures, prophylaxis of eyes and thighs, and like repairs can be done to the perineum while the baby is doing skin to skin, as long as, you know, everybody is stable. Set goals for the organization to increase and improve skin to skin for nutrition and breastfeeding, initiation and continuation. Optimizing electronic health records or charting with the IT team to sort of make that easier to flow and or access for everyone. And with that being said, you might need to incorporate job aids for documentation, flyers, or even rounding, you know, prior to the shift start, to give them updates or focus on any kind of areas that might need improvement. Of course, and always seek out a champion provider to pave the way to serve as an example of the possibilities to prioritize skin to skin in the OR. And of course, task force and committees about related to newborn nutrition that incorporates that skin to skin in the early hour and throughout the stay, but as well as initiation of breastfeeding. So changing the culture, I feel like this is, next slide, sorry. Changing the culture is probably going to be the biggest thing or obstacle that can probably come with people. So discuss change in positive terms, collaborate with team representatives. Here it would be the L&D, recess team, and the admit team. Communicate rationales effectively to nursing staff. The reason we are successful is that we have created a culture and practice that every spontaneous vaginal delivery goes belly to belly immediately after birth, if and when stable. So of course, like I said, change is hard, involve everyone, you know, seek out champions. We have a provider here that she prioritizes skin to skin with all of her deliveries, and collaborate. Next slide. So thank you very much for joining us. We're going to open it up to see if anybody has any questions.
Thank you, Jessica and Jeanette. Yeah, I put in the chat that we are hoping that some of y'all will have some questions, thoughts, comments, things that came to mind. You know, one of the great things about this being a collaborative is learning from each other. So again, really big special thanks to the team at Northside Gwinnett for being willing to kind of put themselves out there. I know when we were working together, they were hoping that some of you all may have some input on any strategies that you've considered or have integrated as well. Feel free to unmute or get in the chat.
Ravi, that was great. It was great to see the work, and congratulations on kind of pursuing this and trying to get some data as well. This is a big, when you think of the number of births, this is a big effort. I wonder if you could talk about how do you get the patients engaged early enough to say this is something I want to happen. So if for example, that they can participate in ensuring, in addition to staff kind of working together. I wonder if you could talk about, what kind of education you have to the patients before deliveries that happen when they enter the hospital. Are they aware of kind of the plan for skin to skin, well before? Do you have thoughts on that or experience with that?
Okay, sorry. This is Becky Moore. I'm one of the lactation consultants. So I would say it's really important to start at the prenatal level. That's something, patients are more impressionable then, and that's the time they're in the frame of mind of learning. So we're really trying to impress that on the providers to see the importance of that. So we do have teaching materials to help to prepare them for when they get to the hospital. So that especially the two biggest ones are the skin to skin after delivery, and also rooming in, that we practice that as well, keeping moms and babies together. So I think just starting at the prenatal level and preparing them, like, this is what you're going to expect when you get to the hospital after delivery. This is what's going to happen. So it's like they don't have to have a birth plan or request it, because that's something we automatically do, and that's in all of our literature.
And if I could follow up, just some of our hospitals might have lots of different practices that might deliver at the hospital. So I wonder if you could, how you kind of engage the kind of various groups of providers that might be delivering at your hospital for work like this.
I think that we try to provide them with teaching tools. Like we've created like handouts, and also just laminated cards that we like, visual things that they can use to teach their patients. So we've tried to address the barriers there. So we have lunch and learn with them, come to the office and talk to them about the importance of it, and then provide them with tools to make it easier for them to implement.
Yeah, you all have coordinated with WIC as well on that, right?
Yes, very much so. I'm glad you mentioned that. One of their, they have an IBCLC that comes to help teach the prenatal education class, the prenatal breastfeeding class. So currently she goes to two of the main, OB groups. She goes to there. So once a month she teaches that class.
I think that's wonderful to see the collaboration. I mean, I know there's always room, those of us who are in this are like, well, but we're not doing this and we're not doing this. But I think it's great to be able to step back and see, from my perspective, it feels like you guys are doing a really good job of looking for those opportunities to provide collaborative continuity of care. That's really important.
We share our audit results with the offices.
Yeah, I was just going to
too,
say that
so-
as well, as we
Yeah.
audit them to see, are they teaching the topics that we've, yeah, that's right.
Yeah.
So we interview the patients to find out, you know, are the providers actually teaching you these things? And if we're not scoring well, then we know that's an area we need to work on.
Yeah, and that's a strategy in itself in terms of how to address when you don't have a lot of resources. Putting them the places that they're going to be the most efficacious is really important, right? When we have limited resources, making sure that they're going to the places that are going to make the most difference is important.
Yes.
Are there any other questions, or do you guys have any questions that you wanted to ask the group?
I just wondered if any other hospitals do skin to skin in the OR. I'm just curious about that.
That does seem to be the biggest area of opportunity. And what was so interesting about your presentation is how when you have, one or a handful of providers that are doing it, it really does kind of open your mind to the idea that this could be more standard, more of a standard of care. Is there anyone in the audience that's listening today that's doing it that would be willing to speak up about how much, or is it only intermittently, or you used to and you don't anymore, or something that you're thinking about that's come up?
Hey, this is Casey.
Hi, Casey. Yeah, go ahead.
I obviously don't work in an OR, but I delivered at Atlanta Medical in the
Personal
OR,
experience. Yes.
and they allowed me to do skin to skin. Of course, I was probably a little more informed and aggressive than a lot of people, but
It was upon your request, is what I'm hearing.
yeah.
Yeah.
Okay.
They were fine. They were really good with it.
Good. Well, I mean, I think that really also points at that, some of the disparities we have are around, when somebody is informed or feels confident or comfortable making those requests, then it's happening. And sometimes when we have patients who may not feel that empowered in a healthcare setting and they're not asking, then we aren't offering it. And that's not good quality of care, right? Quality of care should have a broad application. So I think that's a good point. Thank you, Casey. Is there anyone else who has questions? I
Hello,
see
this
a
is
couple in
Fina.
the
Can you hear
chat.
me?
Yeah, go ahead.
Hi, can you hear me? I'm sorry, I'm on the phone.
Yes.
Oh, hi. This is Fina George from Emory University Hospital, Midtown.
Yes,
So
hello.
I just wanted to add that we do skin to skin in our OR, and it has been going well. But again, preparing the patient and who really wants to do it is, really is the key. But we do allow them to go as the baby comes out. The baby does get a quick assessment with our neo and then go right to the mom's chest. If mom is not able to do in the OR, we will have dad do skin to skin. And then they will continue that and go to the PACU and then continue skin to skin there.
Wonderful. Thank you for sharing.
No
Do you
problem.
have any tips on how you made that transition that might be helpful to some of our other teams?
Well, yeah. Well, we are a baby-friendly designated hospital for the last 7-8 years now. So initially it was a challenge, but working with our anesthesia partners was very key, that they were comfortable with it. So initially when we started our journey, we were just doing for vaginal, and then of course working with anesthesia and having them work along with you, and that kind of really helped us. And of course, educating our patients right from the beginning and really asking them if that's what they want to do, and then they would insist. And so we do have a policy created for that, how to help patients do that. So I think having that, relationship with anesthesia is very important.
Thank you for bringing up that particular angle, because I'm thinking back on the slides, Jessica and Jeanette, about having your breastfeeding committee have representative from all the different decision-making groups and representatives from all those different provider types is something that may not happen in a lot of, that might be an area of opportunity in general for a lot of our teams that are participating in this initiative, is reaching out and making a more collaborative, cross-collaborative team that involves, somebody may not think, oh, we need an anesthesiologist on our GaPQC learning collaborative, but it would be great if you did. So thank you, Sina, for jumping on. There's a couple of questions in the chat about annual staff competencies. We're kind of running short on time, so I can get back to both Deborah and Kelly and connect the team at Gwinnett at Northside Gwinnett. I did so well up until then. And then I'm going to pass it back over to Kimberly.
Thank you. Thank you, Claire, for facilitating that. Thank you to our team at Northside Gwinnett. It was wonderful to hear from you all and everything that you were doing. We do have some references from the work that they shared, and we will be sharing these out after the webinar when we send our follow-up email. We'll have links to all of these references there. And just a final thank you. The audit for September is going out on September 19th. So for our data leads, be on the lookout for that. And if you do not receive that, if you're a data lead, if don't receive it by the afternoon of the 19th, reach out to me to make sure it didn't get lost in a spam filter. And our October webinar will be on October 11th. So look out for more details on that. And that's it. Thank you all for being here today, and have a great afternoon.